What's going on, Tiffany, with the PARP inhibitors that you're aware of in the curative setting?
Yeah, so the Olympia study, building on Olympiad, is an early stage trial of a randomization to adjuvant olaparib versus observation or standard of care radiation, endocrine therapy if appropriate. And that's a global trial, still accruing, and I think a really important one for women with early stage germline BRCA mutations. And in the setting of triple negative breast cancer, if those women did receive neoadjuvant therapy, they need to fail a path CR to be able to be a candidate for this trial. But I think that is one very compelling and important and worth keeping an eye on. In terms of other areas of interest, we've alluded to how important it is to figure out some of these other germline mutations and see if there may be a role for PARP inhibition there, as well as a potential role for somatic non-BRCA mutations.
Mm-hmm. And there's some work, I think, going on in the neoadjuvant setting too.
Yes, I think we're at ASCO, we're likely going to hear about some monotherapy talazoparib results in the neoadjuvant setting. I think Jen Litton at MD Anderson has completed enrollment to that trial. So I think we're going to hear about that. And I think other PARP inhibitors alone or with immune therapy are moving into the neoadjuvant setting. So I think there's going to be a lot more, and I think you're absolutely right. I think if there's a study and there look like there's some exciting results, the need to not miss a germline right from the beginning is going to become paramount.
Be huge, yeah. So that'll be interesting. That's going to be our first data just in a few months about preoperative talazoparib single agent in the BRCA germline.
Yes,
was it
germline
both
BRCA.
Triple negative and ER positive?
I don't know the answer to that because I'm not sure.
Yeah,
we'll have to hear it out.
Right. Yes. And I guess the other thing is, it is tempting to, think about, olaparib and hopefully soon to be talazoparib as well for the germline mutations that are similar to the BRCA 1 and 2, like PALB2. I think of so similarly as BRCA2, for example, and they oftentimes will have triple negative breast cancer there. What do we know from other malignancies? Do we have any? Because we don't have any data in breast cancer yet, do we?
I will say that TBCRC, we've just opened a study looking at this question in breast cancer, looking at either germline or somatic other DNA repair mutations in other DNA repair genes, or just somatic BRCA mutations to see if olaparib will work. And prostate cancer is the cancer, the Mateo study in the New England Journal, that really showed some success with olaparib with either germline or somatic mutations in, for example, ATM. So this was a cohort in which they gave all of the metastatic prostate cancer patients with castrate-resistant prostate cancer olaparib, and they looked at who responded, and of the 16 patients who either had both copies of a gene mutated or both lost one of these DNA repair genes, 14 of the 16 responded to olaparib. So I think the key will be, again, just another way to get to these patients who don't have a germline BRCA mutation, who may have the same defect in this homologous recombination pathway. Another way may be just having a different mutation in this pathway, either in the tumor or germline.
Either way, and it was both somatic or germline.
Yes, when they saw, for example, ATM mutations in the tumor or BRCA2, only half of them were germline. Some of them were just somatic in the tumor. So that's promising.
That is promising, but they thought, probably you might need to have both copies of the gene gone.
Absolutely.
That still has to obviously be worked out, but with only one, you still may have enough gene function there that you're not going to get a good result. So we have to be careful, because now when we send our tissues, because we're looking for clinical trials for patients, we're looking, they had standard therapies, we're looking for mutations that might qualify for them, clinical trials, next-gen sequencing, and it comes up with a BRCA2 mutation somatically. We don't know now, whether that's really functional, right? It's not reporting out that what the, is it both copies gone, or biallelic loss, right? So we would have to call up and find out. But your point, though, I think, Nadine, is, you would say just go ahead and do the
treated.
germline.
I think in these studies post hoc, there will be a lot of analysis about who responded and who didn't. I don't think there's a way in real time at this point. Obviously, if it's a germline mutation and the cancer is a signature one, breast or ovarian, there's a presumption, and actually many have shown that there's loss of heterozygosity for that loss of that wild type BRCA allele in the vast majority, 80 or higher, 90% of the cancers. So that, I think we have that assumption. I think what you're raising is if it's arose somatic only in the tumor, how do we know that both copies are really non-functional? We won't in real time, and we'll have to look at that.
So thank you guys so much. Really thorough, deep discussion. Just want to give you the opportunity to, leave us with one, or a couple of sort of take home messages, that you're gonna, that for all of us who are just, kind of getting used to these data and such.
Yeah. I feel like I'm stealing Tiffany's because she revealed it, so
mine may still be the same.
I would say that in metastatic breast cancer, don't forget to think about finding a germline mutation. It's really what Tiffany had said before, because now we have a new therapy. It's not just about preventive surgery and preventing new cancers in the future. This is about treating this cancer. So you can't forget. You have to think about how to test for it. I think I've started.
I would
this.
echo that. Yes. We'll leave more time for question and answers because I would say the same thing.
And that's going to help us, I think, as we focus more and more on the metastatic setting. It's going to raise the consciousness in general. Probably it'll spill over to the patients we're seeing in follow-up. So it'll be part of our algorithm that we go through, and more it is anyway. I think with these other germline mutations out there, we're thinking, I find myself, redoing the family history, et cetera, but it'll probably raise the consciousness in general for the whole area and spill over into the curative setting. So just the beginning. So, well, thank you guys so much. And I think this has been really an excellent discussion. We hope that you found the information to be very valuable for your clinical practice. Thank you for watching OncLive News Network.